Great. Well, hello, everybody, in our virtual world. It's so nice to be with you. I really have to say I appreciate how complicated and challenging these times are for all of us. And so I just want to say I really appreciate all of you who've taken time out of your day to be with us this afternoon. And thank you so much to the NYU Aging Incubator for giving me this opportunity, along with my colleague and dear friend, Lydia Miselides. I will tell you about her momentarily and the work that we do together, but I'm grateful to the Aging Incubator for providing me with an opportunity to introduce all of you to her and some of the important work that we've been doing together recently. So today we will be talking about what I personally think is a really overlooked area of important individuals who are very vulnerable to the effects of this pandemic. That would be the older adults who use adult day programs, and really talk to you about, in sort of a question and answer format that leverages Lydia's expertise in this area, about the impact that these centers, and the effects that this pandemic has had on the centers themselves, their viability, as well as the really vulnerable people who use them on a day-to-day basis. So with that, I really want to take a brief moment to introduce all of you to Lydia Miselides. As I said, my name is Tina Sedrngani, and Natasha, if you don't mind advancing to our next slide so you can see Lydia's beautiful photo. I will say that Lydia and I have worked together for quite some time now, over the last couple of years. I am currently an assistant professor in the NYU Rory Myers College of Nursing, and here at NYU. And I currently work with Lydia on a lot of my research in adult day programs. So Lydia has enjoyed, according to her bio, a 35-year career in public policy, in program development in aging, mental health, and disabilities. Lydia earned her master's degree in health administration from the University of Southern California. And she was for 30 years, the executive director for the California Association for Adult Day Services. She's currently serving as the executive director for the Alliance for Leadership in Education, which is really the research and development arm of the California Association, about focused on how we can improve and innovate with respect to the care that we provide to older adults in the community. Under her leadership, ALE has raised more than $4.6 million in philanthropic funding and donations, which has also financed some of the work that we've done together, really focused on improving and coordinating care for vulnerable populations. And I'm sorry, Natasha, I don't know if you can hear me, but if you can, could you move to the second slide, please?
No problem.
Thank you. So Lydia was appointed in November 2019. So we really keep her busy. She mentioned something about retirement a couple of years ago, and we're just not letting that happen. So in 2019, she was appointed to serve as a member of Governor Newsom's Long-Term Care Services and Support Subcommittee for California's Master Plan on Aging, which I'm excited to hear a little bit about today. And she also serves as the secretary of the board for the California Aging and Disability Alliance. She is on the steering committee for California Collaborative for long-term care services and supports. She is extremely experienced, and we are very lucky to have her with us today. And I'm so excited to introduce you to her because my colleagues in the College of Nursing know her as Tina's buddy in California, who I do a lot of work with, but I'm excited to have her with us. So Lydia, did I miss anything about you that you want to mention?
No, Tina, that was a lovely introduction. I can just say I am sheltering in place because I am of that age of over 65 with my husband, Labrador, 2 cats, and my son. So
wonderful.
Here I am in California. Yes.
Okay. And I do want to ask all of you, because I can't see them on my screen, but please just let us know if you can see that Natasha has advanced the slides. So if you could just write yes or no if you can't see the slide with Lydia's photo on it front and center on your screen, please let me know. Okay, no. So Natasha, our panelists can't see the second slide.
The second slide.
Yeah, slide 2.
Slide 2. Okay.
Thank you. And if, yes,
no problem.
Perfect. And if you want to put it in slideshow mode, it might be easier for everybody to see the full.
Yes. Can everyone see? Okay. Great.
There we go. Okay, a few can't see it yet.
Let's see. It's in presentation mode on my end. Is it not showing up on anyone's screen?
Fortunately, we will be, it's not in presentation mode is the feedback that we're getting.
Oh, it's not in presentation. Let's see, new share.
Fortunately, most of this will be in a sort of question and answer format. We do have a couple of slides that we thought we would show you that sort of reflect some of the work that we've been doing. And so we can, you know, Lydia, while Natasha kind of works on that, you and I can go forward. But so I think what is abundantly clear to all of us is that frankly, this pandemic has not spared anybody. And there has been, which I think is a good thing, a tremendous amount of attention to the health of older adults during COVID-19, particularly those in long-term care settings. Those are the individuals, as we all know, that are the most susceptible to the effects of COVID. And yet, most of the public and media attention that we've seen has been focused around nursing homes and institutional facilities, and those settings have been ravaged by this pandemic. But you know, what we often don't realize is that adult day programs are a type of long-term care setting. Yes, they're non-residential, but they exist in the community, and they frankly serve some of the most frail older adults, which in our communities, people in many states, the people who use adult day programs tend to be people who are nursing home eligible. And so these individuals in normal circumstances benefit from socialization with peers in a congregate setting. And yet, because of the pandemic, many of these centers have been most centers, in fact, have been ordered to close, though in some states they are deemed essential and have remained open. And so what really the point of this webinar today is to take a minute to draw all of your attention to this extremely vulnerable population in this setting and go from there. So, you know, Lydia, I really want you to sort of give us all a primer, as you did for me at my start of all of this. I find that many people, even if they're experts in geriatrics and gerontology, they don't really fully understand and appreciate the scope of services that are rendered in adult day programs, as well as the complexity of the population that's served in these settings. So why don't you start by telling us a little bit about adult day programs? They're not senior centers. They're different. How are they different? Who pays for these services? And typically, what services do individuals in centers receive in normal times?
Thank you. Thank you, Tina. Thank you for inviting me today to join you for this Aging Incubator. Very excited to be here, everybody. Well, you've really kind of hit the nail on the head. One of our challenges over all these decades has been to very clearly be able to describe what the services are provided in adult day services and who we serve. Because often the impression is when you walk into a center, and it is a place, it is a daytime place, what you see and what greets you upon entering the center is usually a very warm, welcoming buzz of activities. And so the first impression often is of that entering into a senior center, but it is much, much more than that, because the people served in our facilities, whether they're a social model or a health model, those are the two distinctions that we make to be able to describe them to the public, is that these are individuals who have complex, both medically complex often, physically, psychologically, socially complex challenges and conditions, and require the services that our interdisciplinary team of staff can provide to them to keep them safe and as independent as possible, as well functioning as possible in their home, wherever they may live. Some live alone, some live with caregivers. There's all the variety you can imagine. And centers serve anyone over the age of 18. So I think that's another misconception,
Sure.
Is that these are centers only for old people. They are not. Most states recognize and authorize centers to provide services to adults. Some might be a little more restrictive. For example, if they're AAA funded, Area Agency on Aging funded, they might be a little bit more restrictive. But the core is it's a place where people go during the day to get their needs met by a team of very skilled individuals.
And could you just elaborate for everybody who is, this type of staff members and the different disciplines that are represented in these studies?
Oh, absolutely.
In these centers.
Yeah, so our adult day health models, they may be called something slightly different in the 50 states, but it usually has health in the title. Those centers usually have to have at their core registered nurses, then LVNs for support, aides, social workers, therapists, occupational therapists, speech therapists, physical therapists, often a dietitian who's on consultation. They often will be required to have a medical director, and again, a consultation from a psychiatrist or psychologist for those who have serious mental challenges. So it is really a team of individuals somewhat reflective of what nursing homes are required to have on hand. And indeed, our early regulations in California were modeled on nursing home regulations. And a little known fact is that adult day services in the United States came to the US from England, where these services were known at the time as a day hospital. So that kind of gives you an idea of what the intentionality is of these services.
Yeah, I think I've always been struck by the fact that here you have these centers that provide this really robust interdisciplinary care. We talk a lot about this in our academic settings. We teach, I work in the nursing school. We teach our nursing students about the importance of interdisciplinary care for older adults. And here you have a setting where that model lives and breathes on a daily basis. And I think that's really what's drawn me to my research in this field, because I see so much promise in these centers with respect to how they deliver care. I would ask you, as far as the population that they serve, you talked a little bit about, they serve everyone over 18. Focusing for a minute on the older population that is represented in these centers, how would you rate their health overall? Are these people who are well seniors going to centers, or could you elaborate a little bit more on their needs with respect to their health and functional status?
No, when people come to the centers, and we wish they would come earlier and their caregivers would come to the centers earlier in their care process. They are people who do have what we would consider to be chronic, ongoing. These are not people who are undergoing episodic care challenges or illnesses. These are people whose conditions are chronic and ongoing. In adult day health care, which is funded by Medicaid in most states, you can now begin to imagine these are very low income individuals who have an array of now what is called social determinants of health challenges with their living situations. Perhaps they're living in neighborhoods that are not safe. Perhaps they have suffered from prior years of abuse, trauma, neglect, and so on. So these are individuals that come as an entire person with a lifetime of illness, of challenge, perhaps, as I said, trauma. And the center's goal using a team approach, Tina, which I know you're passionate about, as am I, is to really support these individuals to meet their own potential at whatever age they are in when they present themselves to us at the center. And we really work with the person and the caregiver and their whole life situation as a team. So I think the centers who began 40 years ago really were ahead of their time. And research has now caught up with the fact that people can live in the community who here previously were thought, if you had an Alzheimer's diagnosis, basically you were told, well, I'm sorry, and nursing home is your next your next place to go. So we really proved that people with Alzheimer's, even in the moderate to severe stages of the disease, can successfully be served in the community through the end of their natural life. And we're very proud that these centers were a leader in being able to show that could happen with this kind of support.
I have to be honest with you, one of the things that in all our work together, one of the things I've been most struck by was I attended a conference in California that Lydia's group CADS put on, and one of the presenters said something. He said that in the absence of a treatment or a cure for Alzheimer's disease, adult day is one of the best treatments that we have out there. In as far as, you know, productive engagement, stimulation, management of behavioral symptoms, respite for caregivers, it really is the full package. And I would agree that, you know, people were very forward thinking with respect to these centers. I think that's a very good point.
Well, and the other thing, Tina, to add on to what you've just said, is every day that is that a person is saved from having to enter, particularly a Medicaid-funded nursing facility, is a taxpayer dollar saved. So the cost savings too is just starting to be understood better, because there has been quite a bit of research done on Alzheimer's and caregivers and cost. But I think that's really an important aspect of what Adult Day Services offers too. It's a lower cost alternative for the taxpayer.
Yeah. The other thing I'll draw people's attention to is one of the reasons I'm so focused in my own work. I know many of my colleagues are listening. A lot of my research prior to my pre-doctoral work was around the health of older immigrants. And I'm very much sort of an impassioned advocate about the needs of ethnically diverse older adults. And adult day services, you know, according to the CDC Center on Long-Term Care Statistics, adult day programs are the most ethnically, racially diverse subset of long-term care. So, you know, and I think there's certainly cultural underpinnings to that about keeping people at home and keeping people in their communities. But what has drawn me so much to this work is that you really serve a very diverse population, and that in addition to providing comprehensive interdisciplinary care, centers are also providing culturally congruent care. So staff is, you know, like the food, everything is really caters to the cultural preferences of the population being served. So in many ways, I think centers do a great job of trying to be the model of care that we really tout over here on our end.
Mm-hmm.
Lydia, my next sort of question that is important for you as such a policy wonk is, you know, are states very similar in the services they provide from one state to the next? Or do states really vary in how adult day services are provided? Because that has implications for how they've responded to the pandemic as well.
It does, Tina. And what you just said is really important. And because you've observed that centers are culturally congruent, one of the reasons I believe for that is because they are intentionally designed to be neighborhood based and responsive to their communities. And so when we think about the similarity or dissimilarity of the services, somebody has said to me, well, if you've seen one center, you've seen one center. And while that isn't entirely the case, there is a lot of variability, and that's partly the reason why, because they are responsive to their communities. And they're usually nonprofit or perhaps family-run or small business operations. And because they're rooted in their communities, they draw from their neighborhoods for food, for transportation, for entertainment perhaps that comes into the center. That does create a wide variety of how the centers may look and feel when you visit one. But ultimately, at the core, they're very similar in their philosophy and how they approach serving individuals. And so in terms of the differences, too, you can imagine not just differences because of neighborhoods, makeup in terms of culture and language and so on, but also a rural center is going to look different than an urban center. It might be because they can't serve as many people. Facilities will look different. Some are brand new, built to purpose from the ground up. Others are in a little shopping center tucked away somewhere where they might be a little harder to find, but that's the best you could do for real estate at that moment. So that's why we see the variety, but I think that's a strength of the program and why they are so embraced by their communities.
Yes, I always like to tell people that they're, you know, my first degree was in anthropology. So I always say the centers themselves are communities within communities, and they're really microcosms of their neighborhoods and where they sit. You know, so shifting from 1 second, you know, going back to the pandemic, which is the issue at hand, is so you have these centers that really in normal times can deliver a very high level of care that enables older adults to age in place and age in their communities, and provide really comprehensive interdisciplinary care. And yet, of course, the pandemic like it has affected everything else and everyone else, it has really had a vast impact on centers. And so that's what we're here to talk about today. Natasha, if you show the group slide 3, and slide 4, if you can see pandemic isolation. These are the headlines. It's killed thousands of Alzheimer's patients while families watch from afar. If you go to the next slide, Natasha, there's striking racial divide in how COVID has hit nursing homes. The headlines have really been focused on institutional long-term care settings. And yet what Lydia and I have spent the last couple of months focusing on and looking at nationally is what effects the pandemic has had on these adult day programs, which really haven't received as much attention, but deal with perhaps an equally vulnerable population. And if you go just, Natasha, to the next slide, you'll see that loneliness has doubled for older adults in the first month. And so the impact of really not having a congregate setting available for you to socialize and for you to be at home isolated is really taxing. And I'm speaking to people who are very much in tune with the needs of older adults and the impacts of loneliness, so you can understand where we're coming from. So Lydia, my next question to you is really how centers have fared in your home state of California and across the US. What are centers telling you? Have they all shut down? Are any reopened? What is the current state of affairs?
Well, I'll start with California, and I know, Tina, you've been talking to other states, as have I, so I think between the two of us, we can paint a pretty good picture across the country. But starting with California, our governor issued a stay-at-home order early. It was, I believe, March 16th. And in that order, which is still in effect, by the way, congregating is not allowed. And since we are a congregate place, centers were given basically 2 days notice over the weekend that they had to stop bringing people back to the center. So it was very abrupt. It was extremely disruptive, but I'm extremely proud also of our center staff and teams and how well the participants and families responded to this emergency and cooperated. And the other thing I'm really proud of in California is that centers, with the exception of 5 out of our almost 400 centers that are health and social model, did not close their doors. They were able to continue functioning, but we quickly pivoted with the state's leadership and support to a remote service model that we call Temporary Alternative Services, or TAS. And that's been in operation continuously since March. It took a few weeks to get our legs under us, to get staff figured out and services designed by the state and guidelines issued, and that is still going on today. 7 months in, I think we're in a little bit more of a routine now, the centers are, but it's still been very challenging, and we're going to talk, I know, a little bit more about those challenges. But I'm very glad that our centers were able to continue operating and supporting our participants and families because the state stepped right in and said, you're an essential service, we want you to keep functioning. But we couldn't bring people into the center except on a very limited basis, like, one-to-one essential care, kind of like appointments in a doctor's office. We could also do some home visits, but because PPE was so lacking, we're going to talk about that, I think, too later, Tina, and testing. Even today, that's very limited. So that's what's happened in California. Almost all the centers are operational. Now, some staff were furloughed. We were able to start services with a core. Now people are bringing back therapy staff and some other staff that were not part of our core at the beginning. So it's still evolving how we're producing these services remotely.
Yeah. And so what Lydia and I have been doing, so that all of you know, for the last couple of months, is working together with one another. We have been interviewing, we've done some one-on-one interviews with centers across the United States to understand how they fared, because as we mentioned, state adult day services does vary from one state and one community to the next. So really understanding how that's been impacted. And then we did focus groups focused in California, because California has, as Lydia mentioned, this temporary and alternative services benefit where they are allowing centers and reimbursing them to a certain extent for providing remote services. And that is fairly novel from a policy perspective. I can share with you here in New York, our centers were ordered shut. They remain shut. There is now, as of 15 minutes ago in my last phone call, there is a sort of draft reopening plan on the governor's desk, and it could be several months, a month before that's signed and reopened. And there's very sort of stringent protocols around how they will reopen, contingent on having appropriate PPE and distancing. Financially, it's challenging for centers because their reimbursements depend on volume. And if you have to have everybody 6 feet apart, that dramatically reduces your ability to have the same number of people in the centers. Also, our centers, as we said, deal with a sizable chronically ill population, many of whom, about a third of whom nationally, have some form of dementia. And so these individuals may have a challenging time complying with infection control policies. And that is, of concern to some of the centers because, as we'll talk about shortly, those are the individuals that really are, whose families really would like them to go back. And so, we did a 2-part study of really interviewing people across the country to hear about what they're experiencing, and then doing focus groups in California to hear about the innovative programs that they've used. And Lydia and I will be happy to share that. I want to talk about some of the consequences that individuals and challenges that individuals and centers are facing as a result of these closures. And so let's talk about for a second the specific challenges. What have you heard, Lydia, as far as what people are facing?
Sure. I talk daily with providers in our state, and I talk periodically with providers in other states, as do you, Tina. So for our state, I can say, as you can imagine, that there have been consequences, even though centers are engaging in remote services. And let me just describe what that might look like very quickly. We're allowed to provide doorstep services. So that could be a socially distant doorstep visit, dropping off food, supplies, equipment. We can engage in, of course, those socially distant conversations at the door. A lot of telephonic check-ins. There's a required weekly COVID check-in and screening. Lots of one-to-one counseling, a lot of Zoom calls, and we're learning how to be IT support, if you will, for our participants and families, which is also has a nice side effect of helping those participants and families connect with their doctors who want to do telehealth visits. So there's a whole learning curve that's gone on right now around screen time, which has been really actually a positive aspect of this. And folks have been pleasantly surprised that even someone who's never touched a screen before has been able to learn. So that's been very satisfying part of this. But I would say that the reports that we're getting and that worry our centers significantly, and why they would like to begin to figure out how to get folks into the center for services, is deconditioning of the body. People are not moving around as much. They've fallen out of a routine. It's very hard for them to create their own routine and structure to the day. We're hearing a lot about depression and anxiety. The social workers are working very hard telephonically to support the participant and caregiver depression. We have heard of placements, nursing home placements, weight loss, hydration. People are not drinking fluids to the extent where they would be during the center, and being reminded. Centers have creatively figured out ways. They're delivering customized water bottles and figuring out ways to incentivize people, for example, to drink water while they're at home. A lot of other exacerbation of their chronic illness symptoms that, again, the nurses are on top of, but without being able to do the hands-on nursing assessment and really evaluate how that person is doing with, Tina, as you as a nurse understand more than most, what is going on with that person. They have to be very, as a matter of fact, we've done some training sessions on active listening, because now we have to use all of our senses over the phone, and that is a challenge and new for most of our staff. They're used to hands-on care, and they love providing it. Yeah. So there have been some deaths. There's no centralized reporting required of deaths or positive cases, so we don't have any data to report on that to you.
And Lydia and I talk often about the importance of data in our world. Natasha, if you don't mind going to the next slide,
No problem.
Thank you. This, I can show you, this is what we're hearing, you know, across the country. I just got off with my colleague in New York who said that, you know, they have lost about 15 to 20% of their participants, whether it's because they've been placed in nursing homes, they have passed away, they have died from COVID. They have had a really, in New York, it's had a sizable impact. The quote featured here is from a center in North Carolina where their director told me that they were actually forced to close. The center itself closed. They lost 8 members, 3 passed away. 3 were, of the three that didn't pass away, 2 were critically ill. 1 was in a nursing home. 2 were put in memory care facilities. And, you know, this program director said that with the eyes of a nurse on these individuals every day, she felt very strongly that some of those placements and complications could have been prevented. And I'm hearing this over and over again from people we talk to across the country. In this instance, it was an individual who's now in a nursing home, had a raging urinary tract infection, became septic. You know, that's something that these centers with their sort of serial clinical observations would have likely caught much sooner. So, you know, Lydia, what you're hearing in California is really pronounced even in other parts of the country, which haven't had the same, you know, not every state is saying, oh yes, you can provide remote services. It was more, you have to close. They didn't, and what I'm also hearing is that there's not been a lot of guidance on how to safely close. So organizations like Lydia's are the ones providing directives and in combination with public health guidance on how to close. But these centers really had to figure out a way to get these people who get their medication at their adult day program every day, their medications while they closed, and make sure they had a caregiver. You know, and Lydia, you also talked a lot about caregiver stress, and that is something that has come up over and over again in our interviews and conversations. Natasha, do you mind going to the next slide? You know, constantly we are hearing that there's so much caregiver burnout. One interviewee at a program director said, because we have some caregivers, especially who are working with folks with dementia, their routines have been disrupted. I'm hearing where their days and nights are getting mixed up. So the caregivers are all up until all hours of the night with them. I mean, you can imagine how taxing this is. We talk, Lydia knows I'm a mom of 3 young children. There's so much conversation about schools, children going back to school, the importance of childcare. But, you know, what would you say the conversation around elder care has been, Lydia? I mean, family caregivers of older adults, particularly those with dementia, do you think it's been enough of the conversation? Because I think if it was more part of the conversation, maybe these centers would be priorities to reopen.
Yeah, that's so interesting what you shared about New York just today, what you learned today. And I think I was reflecting that in our state, and maybe it is because we had continuous services, even though they shifted to remote, people were still connected and engaged, and they had eyes on in a different way. We have not seen a very large decline in our participant enrollment since March. I just looked at the statistics yesterday on the state's website, and it looked like maybe about 800 less than what we started with. So some people are declining services voluntarily for whatever reason. They feel like they've got it covered. They might come back. They're being put on temporary hold. But I wonder if that's one of the differences that we're observing here. But to your point about caregivers, I think this we didn't ask for this, but we're in a natural experiment, right? Yeah. And I think what we're learning is how critical adult day services is to the caregiver as well as the participant, and that you can't replace adult day services with long-term in-home support. Right. They're qualitatively different. Both are needed at times, but as one of my pioneering leaders in California once said to me, probably 30 years ago, and I've always remembered it. I mean, she looked me straight in the eye, and I knew something serious was coming that she was going to say to me. And she said, Lydia, I want you to understand a person can become institutionalized in their own home. Mm. And those words struck with me. I didn't quite get what she was saying, you know, when I was 30 something, sure. But it's really true. And we see that now, that being sort of locked away in the house with a shelter-in-place order, it means a loss of socialization with your peers, leads to apathy, feelings of loneliness that we know are harmful in terms of health outcomes, depression, loss of independence, and so on. So for the caregiver and for the participant, I think we're really seeing the impact of loss of those services, and remote services are not going to completely replace it.
Yeah. In fact, Natasha, if you go to the next slide, you'll see a quote that really speaks to that. Our friend Carl has already left his house and became lost. My friend Anne is just nonstop. She's being cared for by her 2 college-age children. I mean, these are people that are just constantly in need, and the families have to be on all the time. They can't be a good caregiver. I mean, I know that when my children are in school, I'm a better mom. And I really, feel that this is very challenging, and I'm very sympathetic to the needs of these families. And so, yes, to your point, remote services are not going to solve everything for everybody. Natasha, if you go to the next slide, we can also speak to some of what Lydia was talking about. There have been really powerful impacts on people's health. This came from a center I spoke to in New York. And when we questioned them on impacts of health and well-being of participants, over 3 months, she said, I'm just looking at hospitalizations we've had during this period of time, 33 hospitalizations. Prior to the pandemic, it was 1 or 2 months. And now they're averaging, about 11 a month. And then they went through, not only did they have 33 hospitalizations, they had 43 ER visits. So what we've been trying, people like me and Lydia, for years, is to quantify really the impact that adult day programs have on keeping people out of acute care facilities, including hospitals and including emergency departments. And I think, we're seeing, as Lydia said, a natural experiment play out. Well, when you don't have access to these services, what happens. And so many of the reasons that we're hearing are falls, deconditioning, chronic disease exacerbations or complications. So, there is a really powerful impact here as far as this pandemic. And Lydia, I think you have said that very well. So as far as places where there's limited community spread of COVID-19. So New York, at least until the last couple of days, but in New York, we've really managed to contain our spread of COVID-19. And yet providers aren't reopening. So what are the challenges? What challenges do you think, if we gave everybody the green light to reopen, what are the challenges that adult day programs will face in trying to reopen safely?
Yes, great question. I am I'm going to be spending the next few months really figuring out how we get to what we're characterizing as a hybrid service going forward, where we'll be providing partial remote, partial in-center, because people are desperate. They're suffering. They're desperate to get back to center life. And I think in talking to some of my other colleagues in other states, it has been interesting how the availability of proper PPE has varied from state to state.
Yes.
And in California, of course, and rightfully so, PPE has been prioritized for hospital personnel, first responders, nursing homes, a little bit belatedly, but it's happening now. And so having access to proper PPE is important. Now, what is proper PPE in the center? Do we need N95 masks? I mean, the science has evolved quite a bit since March 2, right, Tina? And so figuring out all of the aspects of protocols for reopening safely to provide services in centers. Some states are doing it. We're going to learn from them. California has been very cautious, but it is my personal goal that we can start the new year with this hybrid model. And of course, access to fast testing. And we know that science is also rapidly evolving. Resistance from caregivers and participants, Tina. You maybe have heard this too, that even for centers who, and we do have centers right now providing in-center services, don't get me wrong, but it's very limited, it's essential. People who, this is the only place they can get a shower. They have a complex medication regimen, so they're coming in for their medications and things like that. But even centers where there has been some offer of coming in for like a reassessment day, hour, not a whole day, there's resistance. So there's still a great deal of fear about COVID transmission outside of the home. That has to be addressed, and it's of course people's choice, but to be able to describe to the community what the center is doing to make it as safe as possible, nothing is zero risk, but as safe as possible, is going to be important. Then there's all the physical physical space. How do you physically distance in the center when we're used to grouping 6 people around a table? Ventilation systems have to be checked and maybe updated in some way. The staff's training and scheduling. If we're going to set up cohorts of people like the schools are doing, right, with children, they're grouping them and creating cohorts. What does that look like? Who do you group? What about people with Alzheimer's who will not be able to wear a mask? Things like that are really vital. And then transportation has also been critical. If the center provides its own transportation, you can kind of go from the home bubble to the transportation bubble to the center bubble and back again, right? You've kind of got a chain of custody. But for those who don't provide their own transportation, what does that look like? And how safe is it? And what are the protocols being put in place there? So there's a lot to consider. And as I said, we in California are talking to other states who are providing in-center services, and we're going to be learning from them and what we can apply here. And then we'll work with our state leaders, public health, and so on to get a little more concrete on what we can do.
Yeah.
But those are some of the key.
And it's interesting. I thank you for bringing that point, because Natasha, if you go up to the next slide on care, just if you look at this, we were talking about caregivers earlier, and many of these older adults, including my own grandmother, who's an adult day user, they live with people who are themselves in sick. We think of caregivers as younger, but some of the caregivers of these individuals who are in their 90s are in their 60s and 70s. Who are very vulnerable to the effects of COVID-19. And so if you look at this quote, it says, when we think of caregivers, we think of children, or we think of younger generations, but many of the caregivers are in their 60s and 70s. And the centers will say that we get calls saying, please take care of my mom. And if you have time, can you drop off some stuff for me as well? And so, there's this vulnerability of an entire household where, people are coming into the center. There's implications for their caregivers. So I can understand that that's extremely stressful. Natasha, if you go to the next slide, some of the other things that Lydia was talking about with respect to financial and operational challenges, the state recommends that members, residents, whatever you want to call them, wear masks. I know mine won't, most of them, especially the ones with more advanced dementia. And then, of course, they furloughed their staffs, as we've talked about, keeping folks in small groups. They said, I've had no income. I've already lost 8 of my participants. To reopen, I would be starting over. And it's, these centers, when I talk to my colleagues in New York, have to really wage marketing campaigns to get people back. But in a time like this, do they really feel comfortable going into, a setting like this? And I think that's going to be a lingering question. Once this is all over, one of the best pieces of advice I got from my colleague here in New York was there needs to be just broader support for all aspects of long-term care, because it's not just, nursing homes are struggling in parts of our state at this point to cover the costs of increased testing, staffing. Adult day programs clearly are going to have to contend with decreased volume and increased costs around infection control and safety. And so we really need to have a broader conversation when things have quieted down on how we can strengthen long-term care. Because in California, where centers are freestanding, in New York, they are all have to exist in partnership with a nursing home. We are the only state in the country that is like that. And so however the nursing homes are doing, if they can't have visitors, then adult day programs can't operate. It's very much in sync like that. So I think, I'm curious, given all your work in California on the master plan, what is the future of long-term care? How can we support it at this point?
Yeah, really good question, Tina. So we can talk about that for a minute. But what you just said also reminded me of a little anecdote I wanted to share with you.
Yeah.
Relative to caregivers. One of our centers, and it happens to be a social model center here in my town of Sacramento, California. And it's actually sponsored by the city, so I'm very proud of that. They were putting together Zoom activities for their participants, and it was with staff creating their own videos. So it was familiar faces, familiar activities, and so on. And what they found is that there was great uptake in that. People appreciated it, but the caregivers started engaging. and then began dominating these Zoom activities with the staff. And so the staff quickly realized that they needed, and it was just going a little too fast because of that. So then the staff needed to create something separate for the caregivers.
Yes.
And they did. So now they have discrete activities for the participants, for the caregivers, and it has worked really well. And now what they're doing is they're making these services available to the broader community on a subscription basis.
Okay, great. So,
yeah.
And that's really a good point, is that maybe, you know, however awful this whole scenario, this pandemic scenario has been, that perhaps there's opportunities to expand the reach of our services. You know, in terms of, we've always struggled with getting, because reimbursement is limited to Medicaid, Medicare plans do not reimburse or pay for adult day programs. We've always talked about how can you expand access to this service, and really the remote programming, especially the ingenuity we're seeing by centers, I think you're right, there's promise there going forward.
Yeah, and we're very proud. The Master Plan for Aging work has pretty much concluded in terms of its public engagement. They're in final writing mode. There will be a plan submitted to our governor by the end of December on schedule. The Long-Term Services and Support Subcommittee, of which I was a member and part of the writing team, submitted on time, right when the pandemic hit. It was incredible timing. And so it got kind of put on the shelf for a little bit, but the LTSS report has also been submitted now. It's part of the Master Plan for Aging. It has done a great deal to open up the conversation across the state with our legislature in particular, policymakers, funders, foundations, and so on. It has really been a place to bring the aging and disability communities together as well. And it is focusing quite globally on not just the low-income elders in our state, but also, but really anyone. And there's a strong emphasis on equity, housing, of course, long-term services and supports, transportation, and we think it is really going to create a blueprint for moving forward in a comprehensive way. And as I said, in all of my decades of work here, I've not seen the aging and disability community come together as unified as it has. And I think now we're going to see a plan that has aspects of the Master Plan for Aging, but focused on disability community, which includes birth through death, right? Our plan, the Master Plan for Aging, includes adults only. So it's been very exciting to be part of that, and I think holds a lot of promise for other states to adopt a process like this, because it's not just the end result that's important, it's the process of bringing all these disparate people together to come up with a unified vision.
Well, yes. But Lydia, one of the things that's so impressive about you and your group is that it's not that California, despite being so forward thinking and progressive in a lot of its aging policies, it's not been without challenge. Adult day programs have not, and so even as recently as the last few months, when the state budgets, and this is happening in New York, where Medicaid, there's really going to be cuts across the board here. There's a lot of revenue shortfalls in all states as a consequence of this pandemic. There are threats to these services. State legislatures are saying, well, geez, you've been closed for this long. Maybe you're not that essential. Maybe we don't need to pay for these services. What's your take on that? What have you experienced, and what is important with respect to policy and advocacy for supports for older adults?
Well, Tina, that's why your research is so critical and why we need more researchers working in this field, and particularly during this time when everything is so disruptive. Our Secretary of the Health and Human Services Agency, Dr. Ghali, says the pandemic has been an unmasker and an accelerator. And so it has unmasked inequity, unmasked disparity, and it has accelerated change. And we're living that day to day. And so to your point about how that impacts now our ability to continue serving in the face of state deficits, we can't print money. We've been warned by policymakers here, administration officials, that the January budget is going to look worse than this year's, and this year's was bad because in the May revision after the pandemic hit, adult day healthcare was put on the chopping block for elimination for the second time. And while we have no illusions that adult day healthcare is sacrosanct and could not be eliminated, we also found this year that there was an incredible outpouring of support, sort of an organic outpouring from the community. Social media campaigns sprang up. Also, the legislature really stood firm in its determination to not allow the same level of cuts and, in our case, elimination to services for older adults happen in the middle of a pandemic. So by the end of the process, at the end of June, adult day healthcare was not eliminated. Significant cuts were not made to other LTSS services, programs, I should say, and yet we are all, geared up for some really bad news again in January.
Yeah, where we're going to have to be doing this again.
Yes.
Yeah. I want to, in that regard, and just to take the next few minutes before we take some questions, to really highlight some of because I think, to your point, you have to be innovative, right? If we want to keep supporting services, we have to adapt to the changing times. And I have heard from, talking to some of your colleagues on the ground, that this pandemic was a wake-up call that we needed some, more advancement and innovation in how we deliver services to expand access. So I just briefly want to share with everybody, Natasha, if you don't mind going to the next slide. And I'm sorry, and go one more, please, to virtual programming. So we see that we're hearing that, wow, people I would have never guessed would learn how to use Zoom, people 90 and over. So, here at the Aging Incubator, I think we all know that we underestimate the power of older adults to use technology. And that's something we've seen and been really impressed by and have to think about as we come up with interventions. Natasha, if you go to the next slide, you can see how programming, so they've done in-person visits. In addition to the caregiver Zoom calls, we're hearing that they're doing in-person check-ins to drop off meals. And, they'll call and they'll say, how's everything? And the participant might say, I'm fine. And then when they show up at their doorstep, they can see that they're completely disheveled and that they aren't fine. And so, that in-person will continue to be important and done in conjunction with the virtual and telehealth components. So if you go to the next slide, Natasha, you can see that in Lydia State, for example, they're doing a lot of care coordination for which they're being reimbursed. In New York, it's not, the reimbursement for these services is less consistent among the Medicaid managed care plans, but I have heard that even our managed care plans in New York are recognizing the extreme value of nurses at centers who can do case management so well because they know their participants. So here in California, you can see they're doing lots of coordination with resources, the food box, the food banks, to make sure that these people, I've done a study in the past with Lydia in California that reveals a lot of food insecurity among certain subsets of Californians who use adult day programs. Most of them, many of them said that they had one meal a day. That meal is usually coming from the center. So what's happening when the centers are closed? They also are dealing with often a non-English speaking population, educating them on how to, acquire certain benefits during this time has been a big role. Natasha, do you mind going to the next slide, please? And here's something, Lydia, I would love for you to talk about briefly is the sort of risk assessments and the innovation in terms of how you identify when you don't have someone in front of you who is the most at risk as a result of the pandemic. And it seems that your colleagues have really come up with risk assessments and screening forms to assess individuals' risk. So what do they look like and what are they assessing?
Yeah, that's been a kind of an evolutionary process too, Tina. We have, through a grant, I think you mentioned earlier, Archstone Foundation here in California provided a small grant to allow me to host weekly webinars, 90-minute webinars with our provider community. And so we've really created this learning community where we're all sharing. Providers can come onto the webinars. We have what we call innovation celebrations, so people can share their innovative ideas. And this whole notion of how do you telephonically assess risk? How do you ask questions in a way that are open-ended so that you can dig a little deeper beyond the, oh, I'm fine, everything's fine,
Yeah.
when you sense it can't possibly be,
Yeah.
is really an art and a skill that people are still grabbing a hold of. And we're trying to support them with some trainings on how to do that. But one of the things that we have been teaching to is that screening questions are one thing, and screeners do not necessarily have to be the nurse or the social worker,
Yeah.
but referrals have to be made immediately. And what we're also training to is when you can, and something strikes you in your screening that needs attention right away, you don't hang up the phone. You get that nurse or social worker or team leader, program director on the phone, do a three-way call, do a warm handoff, and get that going. Or you'd follow up right away. So the risk screening has been important, but also a bit challenging for the reasons I described. And we're going to start focusing in the next few weeks at our webinars on sort of a deeper dive into doorstep services. So how, as you just mentioned, how can you use the doorstep service to be able to evaluate how someone is doing? So we have some nurses reporting they're doing med reconciliation. They're bringing their own chair, their foldable chair, and putting it outside and sitting socially distant with the person so they can interview them. We're teaching people how to do their own blood pressure readings, dropping off blood pressure equipment. Scales. Some nurses are bringing scales with them so they can check on weight loss or gain. So I think that the important part now will be to be able to combine both the telephonic screening and some interviews that are a little bit deeper than a screening that staff are trained to do, along with some eyes on rather, of the participants, especially those where we know because of their pre-existing conditions are at higher risk.
I think one of the most novel things is that you've shown me of late is, in California, they're really calling this idea centers without walls, right? Like this idea that the work of the center should not be, in this situation, certainly confined to the four walls of the center, that to really make a powerful impact on having a powerful impact on outcomes, which Lydia and I have been studying through various programs over the years. You really need to integrate the care that they're receiving in the center with other aspects of their life. And in this case, these nurses are bringing the center to them. And I think some of the programming that they benefit from that allows for productive engagement, they have been especially innovative with respect to that. So, we were talking about risk assessments, telehealth, care coordination, that's great. But many of the centers, and I apologize that I don't have a quote here for you today, but what I'm hearing is a lot about how they're leveraging resources within their community. So local museums, a class from a local university, all being given online to their participants. Yes. Where they're arranging for the participants, and they're saying, okay, you're going to log on to Zoom at 2 o'clock, and we're going to meet the curator of our local museum in town, and she's going to give us a walkthrough, and you'll have an opportunity to ask questions. Or we're going to do a class today on this poet, and really gauging their interests and bringing aspects of their community to them. And then what can't be replaced virtually, it seems that they're doing, they're finding ways to do in person. And really, by doing these doorstep visits, wouldn't you say, Leah, it's what I love about Adult Day. They help overcome so many of the access barriers, the transportation, the coordination, the supply, they really make it happen for these individuals.
What has been so amazing to me, I'm not a provider, but I know our providers so well, and I've been so proud of them because they have yet again demonstrated their resilience and their creativity. And staffer, if you can imagine too, this isn't the job staff signed up to do.
No.
Right? And they're dealing with their own family situations and perhaps their own, worries about COVID exposure and so on. And so the model for tasks was really designed to be as flexible as possible. So staff have risen to the occasion. We have staff now outside of their comfort zones doing a YouTube video on how to create your own sanitation wipes, your own wipes, inexpensively. We have people whose talents for crafts have now been uncovered, and they're creating activity kits, individualized activity kits. So that has been also a really, I think, fascinating aspect of this pandemic, is to see and observe how people respond to the emergency. And we also know that for some staff, it's been very stressful and anxiety producing, but it does appear, this is only anecdotal, that there hasn't been a large exodus of staff. Some have been furloughed, but it isn't like people are, I'm out of here, you know, we're done.
Yeah.
They are really rising to they're dedicated and they're really rising to the occasion. So that has been really interesting. And then also the resilience of the participants, as you mentioned, and the caregivers.
Yeah.
And while it's extremely stressful, people are suffering. We've also seen this greater bond develop between the center staff and the caregiver that was not able to happen when we were sort of closed behind four walls. So I think what the big learning for all of us is, to the extent that we can break down some regulations that have inhibited centers from really being able to be more person-centered by being able to engage the caregiver more and visit people in their homes more and so on, I think it's going to be a real breakthrough for the future. So I'm looking forward to what the future might bring once we get through the worst of this pandemic, and we can test some different models to really provide services where and when people want them and in the way they want them delivered.
That's great. And I can say that Lydia is really, as a researcher, the best community partner you can have, because she really values the ingenuity. So with that, I want to open it up to questions. I don't know if we have any already, but I will say that, you know, Lydia, I'm so grateful for the opportunity to have you here so that you can share your knowledge of this field in particular with so many people who are interested in improving the welfare of older adults. And I will say, you know, other things that I'm hearing as some of the most creative ideas, I've heard it was Christmas in July, with centers having drive-by events, drive-in bingo nights, sometimes just one-to-one, so a caregiver could go to the grocery store and watching, you know, their loved one while they do that briefly. People have come up with really great ideas. The other one that I heard that I thought was interesting here in New York, they partnered with the local TV station, and they created they did their day's worth of programming on the local TV station. So they had an exercise hour, they had a knitting hour, they had a yoga hour, they had a jokes hour, you know, and the TV station was presenting it. So for people who perhaps had access to a television, but couldn't really grasp Zoom, they were able to feel like they could connect with some of their daily activities and have it.
That's great. Yeah.
Yeah. So really just so much creativity on the part of centers. And yeah, go ahead.
Oh, I was going to add to that too. We just had on our Innovation Celebration webinar a description of a drive-through flu clinic that the center sponsored with their local pharmacy. And it was a big success, and they're thinking about doing another one. So I'm hoping that will motivate some other centers to do the same, as we're entering flu season right now, and we all know what that might look like. So just the creativity has been really wonderful to see in the midst of all this hardship.
Yes, and I will continue to. We have actually our first question that's come through, which is, what are the specific strategies to manage the situation when people with severe dementia won't wear a mask when the centers reopen? Mm-hmm. Like, what are we going to do in that scenario?
Yeah, and this is where that's an excellent question, and one that we have been grappling with as we think about reentry. And again, we'll probably be learning from some of our other state colleagues. But to the extent we can maintain some social distancing, and where everyone else is masked, if we can have some rapid testing available that we can do at the door and screen. I think that we'll be able to figure out how to safely serve those individuals. But it is going to be a little bit more of a challenge. I completely agree. So I think it is going to be a bit experimental as people gradually bring folks in and sort of test out some different aspects of care. The beauty of California right now, other than, of course, the devastating fires, is our climate, where we can extend the outdoor activities further into the season than perhaps some of the other states can. So I think that opportunity to do some things outdoors, especially the centers that have a nice open space, it's fenced by regulation, we might be able to find some solutions there. And clearly, we won't be serving people 6 hours a day. So
Right.
it's the distance, the time, exposure, and so on. But we need the testing. We need good access to PPE and so on.
I think, and also in response to that question, I think we can learn a lot from schools as well, because, young children have, are likely to have, I have a kindergartner who goes to school every day wearing a mask. There are challenges to that. There's mask breaks, there's different things that they've instituted, getting practice wearing a mask, finding comfortable masks. So I think, I think that we can learn some things from other settings that also have populations where compliance with mask wearing may be challenging, and learn from them as well. And Natasha, I know that Bei Wu, one of our aging incubator directors, would like to make a few comments. I don't know if she has the ability to do that.
Oh, yes, I can go ahead and make Bei a panelist.
Okay, great, because we would love to hear from her.
Mm-hmm. Okay. Hi, Bei. Are you able to go off mute?
Yes, yeah, I can. Thank you.
No problem.
So, yes, thank you, Lydia and Tina, for such a wonderful presentation. This is quite thought-provoking. So it's very interesting that actually 20 years ago, when I finished my dissertation, that one the area, actually, my dissertation looked at different kind of types of services available for community drawing older adults that caregivers provide care for. So actually, that look at racial ethnic kind of differences, that one consistent findings that I found is that adult daycare is the most popular service across racial ethnic groups. So that is the most popular program, because people think about that some, there's homemakers, all these people, and some people are not comfortable inviting strangers to come to their home. Mm-hmm. So having these kind of adult daycare, so they can drop their loved ones at your center, or you provide transportation for them, kind of transfer them to the center. So this is very popular. So thank you so much for doing that. That certainly speaks the needs and for people that who really like to. So another actually comment, I'm looking at the slide that you're showing, is that you created a risk assessment for this COVID. My colleague at NYU Langone and I, we actually also have our one grant application currently under review, that we are actually trying to test this kind of risk assessment, COVID-related risk assessment, as a part of our telehealth kind of services that we provide. So something that I would be interested in kind of the compare notes and see what kind of risk assessment tools that you developed versus that we have. So it would be very interesting to see. We're looking at actually New York City.
Yeah. Dr. Wu, I would love to follow up with you, because what we found, the initial tool that we put together very quickly was confusing. There was a COVID screen specific for like the CDC questions, which we know now have changed, and so we're updating the tool. And then the other section was sort of, screening for immediate risk, but we were kind of in an emergency mindset then. So it's like, let's make sure we're checking these things as we talk to people weekly. Well, what happened is it was very confusing, because there was some thought from our regulators that that meant you needed to have specific disciplines within their scope of practice do specific risk assessments. And that wasn't the intention. It was to be like a quick screen. So we're now revising it. So I would love to see what you are working on, and that maybe we could be another test site for you. We're going to be revising that form and launching it soon. And we're trying to avoid confusion. So would love to talk offline with you more about that.
Sure, yes. And Tina, you have my email address. Yeah, feel free to share. So that's wonderful. I have another question is that think about now telehealth. So I understand that CMS has actually opened the door for kind of more payment for telehealth services during COVID. But I just wonder, what's the current status of this? So it's still open for cover quite a range of services for telehealth at this point. What about adult daycare?
Right. So telehealth covers, well, let me back up. Adult health is not reimbursed by Medicare, and so that rule doesn't directly apply. And because we're a bundled payment, and most states are bundled in some way, different ways, but they are typically a bundle of some sort, the ability to provide services via telehealth, telephonically, Zoom and so on, using screen devices is allowed under the waiver. So what we'd like to see is that go forward in our state of California through our regulatory process as a permanent feature of what centers can do as part of our bundle. Now, maybe there will be, a different way we'll have to look at it, but at least the physicians that I speak to and who are following this policy as you are closely really feel like medicine is being transformed during this very moment of time as well, and there will be an incredible push to keep telehealth and keep that in the repertoire of doctors. There's been some national polling done on telehealth too, and it seems to be increasingly popular with people.
I will say in New York, the managed care plans, the Medicaid managed care plans here for long-term care, they have been very selective about which centers they're allowing to do telehealth. So, so there's only a handful that have been authorized and that have actually received reimbursement. I think early in the pandemic, though, the case managers were finding that the day centers were excellent at doing case management and care coordination, even better than the managed care nurses who were responsible for this, because they had such intimate knowledge of their participants and their social circumstances. And so basically, it's been, unfortunately in New York, it's been very selective, unlike California, where it seems to be an across the board reimbursement. So I think that's something we could advocate for here.
Yeah, wonderful. Another question, then that would be the end of my question, the last question. So think about the concept of a digital divide. So I understand that you have, it's wonderful to kind of teach all the adults to use Zoom, etc. So how actually, so particularly your centers are working with people from diverse population and also low income. So how actually do you address these kind of issues?
That's an extremely important question you're asking, and one we haven't solved yet. We just had some training from the Telehealth Resource Center. There is a resource center in every state of the union. And we were able to discover through them, as well as some other of our members, some resources for getting digital devices into people's hands who are low income. So that was one thing. We don't have a statewide study on this yet or survey, but again, anecdotally from my crisis team, it appears that maybe it's only about 30% of participants who have access. So we're leaving out, as you describe, a huge number, which is where we have to come up with other creative ways. And we're also hearing from our centers who do serve ethnic populations that they are struggling even more so. The other challenge that's come up around screen time is for someone who is sheltering at home with a family unit, there's now competition for devices. So even though you have a device, you may not have access to it because it's needed for the school-age children or the grandchild or the whoever. So we haven't solved that by any stretch of the imagination, and we need more resources being put into bridging that digital divide, absolutely, and finding alternative ways, which is another reason we need to get back to some level of center life.
Oh, yes. Yeah, absolutely. Right. It's not only device, it's also access to internet. So even actually, for example, New York City is trying to provide a free iPad to all the adults, but then you're thinking about what about the internet access? Yeah. So yeah, it's a huge challenge.
Huge challenge, yeah. Thank you for raising that. Yeah.
Thank you, Bev. Okay. I don't see any additional questions. But with that, I want to, really say thank you again to the Aging Incubator for having us. Lydia, thank you so much for your time and your expertise and sharing that with so many friends and colleagues here in New York. And Natasha, many thanks to you for organizing all of this. So please don't hesitate to reach out to those of you who know me, and I'm happy to connect you with Lydia with other questions. And I thank you again for your time and hope you all have a lovely weekend.
Thank you, Tina.
Thank you.
Thanks for having me.
Bye.